Okay, we'll get started with our oral presentations. We have a very exciting session today. We have broken it down by themes as best as we could. The first session is cells, clones, and circuits, where histiocytosis begins and persists. And the first talk is by Dr. Benjamin Durham from Rutgers Cancer Institute. Topic is ARAF mutations drive histiocytic neoplasms in vivo and provide insights into cellular origin. I also wanted to alert that we now have a mic there. If anybody has a question, they can walk up to the microphone and ask the question. Please welcome Dr. Durham.
So good morning. Let's see. See how I find out how to advance the slides. Okay, there we go. Okay, so today we'll be talking about ARAF mutations, how they drive histiocytic neoplasms in vivo, and what information we've gotten about the insights of cellular origins so far in this very initial part of the mouse model. So I have no disclosures. So histiocytic neoplasms, we well know, started with BRAF V600E alterations, and the second most common alterations are MAPK1 in both LCH and the non-long ground cell histiocytic neoplasms, where Erdheim-Chester disease belongs. And then, although it's a smaller number of the pie chart, the ARAF alterations, we do see there's an addiction to MAP kinase signaling, receptor tyrosine kinase signaling, aberrant signaling, and histiocytic neoplasms. But ARAF, it represents, across histiocytic neoplasms, it represents about 2 to 5% of diseases, but it's very enriched in histiocytic disorders compared to other cancer types. So it gives us a unique way to actually evaluate how this affects hematopoiesis, how this affects cancer, the initiation of cancer in general, because it's much more enriched in histiocytic disorders than it is in other cancer types. So this is one of the recent paper we published in Cancer Discovery from Memorial Group, and a lot of publications we had, a lot of collaborators we've had across the world, looking at 500 plus alterations, and then of course ARAF is of course about 2 to 5% of these cases, but of course BRAF being the most common, and MEK1 alterations being the second most common, which we talked about last year with the MEK1 mouse model. But we just first discovered ARAF alterations, the S214A, in ARAF, which is another important RAF alterations in the MAP kinase signaling cascade. In an Erdheim-Chester disease patient we saw many years ago in our first cancer discovery paper that actually had encasement of the optic nerve when was going blind without the treatment. And then we eventually started a multi-kinase inhibitor, actually sorafenib, on this patient, and they actually improved, and they improved well with that multi-kinase inhibitor at the time. This is before we were doing MEK inhibition. And we see this time we didn't know a lot of different alterations in ARAF, how they're activating or not. But the S214A, as well as many of the other alterations across the coding regions of ARAF, show activation of ERK signaling as expected. So we know that they're activating alterations in both bone marrow and the other hematopoietic tissues within human samples, as well as within cell lines. So, of course, vemurafenib was, of course, cleared in 2017 for BRAF V600 mutated histiocytosis, and then we did a trial across that was molecular agnostic, basically, where ARAF was responding well to MEK inhibition. So it's unlike with the MEK1 E102 under 3 deletion, the mouse model discussed last year. The ARAF model seems to respond well. The S214A does respond to MEK inhibition, but it's more about how does this actually cause the pathogens of disease. It's the important direction of this. So some other questions like we have is, okay, how does ARAF cause histiocytosis to develop in general? Within mouse models, when you express at different stages of hematopoietic development, because again, how does ARAF affect neoplastic hematopoiesis? We don't know. So that's one of the directions. So we want to study on this. Also, although MEK inhibition works for this in some cases, what's the actual best target for ARAF? Because there's actually new therapies out there that are actually RAF dimerization inhibitors and things that could be very useful in other cancer types that really should be explored in ARAF-driven histiocytic neoplasms. So a potential model for looking at that would be useful. Because of ARAF's enrichment in histiocytic neoplasms, about 2 to 5% of disease, we decided to make an S214A. The codon S214 is the most frequently altered of the ARAF alterations across histiocytic neoplasms. So we decided to create a mouse model by knocking the ARAF mutation S214A, which is the most common of those, into the endogenous locus of ARAF within the mouse genome. And then of course we had a Cre negative. We saw activation of both the bone marrow and spleen. Spleen mononuclear cells, but from MAP kinase signaling, so we saw it's activating in these mice when in the MX1 Cre positive mice. When we expressed it at the early stage of hematopoietic development under MX1 Cre, which that is the short-term stem cells, the multiple progenitor cells, and the long-term stem cells before you get to committed myeloid progenitor, or before you get to committed lymphoid progenitor. And the Cre negative mice before Cre recombinase in Cre negative ARAF mutant mice. They actually do not show that we don't show the mutation when we evaluate the bone marrow mononuclear cells by next generation sequencing. But when it's expressed under MX1 Cre, and you splice out the wild type ARAF, the ARAF exon, you're actually now expressing now showing the mutant ARAF exon in this conditional knock-in model after Cre recombinase using poly-IC. We were able to see the mutation present by next generation sequencing in the bone marrow mononuclear cells and the spleen mononuclear cells. And now these mice, they develop a lethal, like a 100% penetrant myelomonocytic disorder reminiscent of histiocytic disorders. And we see that they don't really start dying. They get more abundant, but they're much slower. It's a much slower activator of MAP kinase signaling than MEG mutations in BRAF V600E. But they start dying. Most of them start dying that are under MX1 Cre expression at about 9 to 10 months post Cre recombinase. And then, of course, most mice live about 1.5 to 2 years anyway, just normal mice. So the other mice, the Cre negative mice, kind of died at kind of normal time points for kind of your typical laboratory mouse. But we did see hepatosplenomegaly in these mice, increased spleen weight, increased liver weight. And when we actually evaluated the bone marrow, spleen, we saw a suppression of B lymphopoiesis. So we saw in the MX1 Cre positive mice, ARAF mice compared to the Cre negative mutant mice. And we also saw, when you look at the spleen in the mice, you put B220 on the spleen. It's basically most of your B cells are depleted in the MX1 Cre ARAF mutant mice as compared to the Cre negative mice. So we see a suppression of B cell lymphopoiesis in these mice. And then we look at the different monocyte macrophage subsets, and we saw under those that have been, we looked at the classical monocytes, the non-classical monocytes, also the macrophages, and we see that there's an increase in both the monocyte macrophage subsets in the Cre positive, in the MX1 Cre positive ARAF mutant mice compared to the Cre negative mutant mice controls. And we also looked at the monocyte-derived dendritic cells, which are CD11B positive dendritic cells. And we see that there's a massive increase of those, which are the type 2 dendritic cells, in the bone marrow and spleen and liver when we evaluate these mice by flow cytometric analyses compared to the Cre negative mice. So we're seeing a massive expansion of the myelomonocytic compartment, particularly focused into the monocyte macrophage compartment compared to, and that's a depletion of B lymphopoiesis, which we do sometimes see in some histiocytic neoplasms, including systemic LCH, systemic Erdheim-Chester disease. And when we look at the tissues, particularly the bone marrow, we use EBA1, which is a monocyte macrophage marker in mice, and we saw massive infiltration of the bone marrow and in the MX1 Cre positive ARAF mutant mice compared to the Cre negative mutant mice. And then we saw this example, I didn't show the spleen here, but this is actually an example of the liver. And we saw huge swaths of granulomata developing in the liver, showing EBA1 positivity compared to the Cre negative mice. So we showed a major expansion of the EBA1 positive monocyte macrophage lineage, also the monocyte-derived dendritic cells within the bone marrow, the spleen, the liver, as we saw in the spleen, a depletion of the B lymphocytes and those that where the ARAF mutation is actually present and expressed. So we're to conclude that ARAF S214A can develop a myelomonocytic disorder similar reminiscent of systemic histiocytosis. and we actually showed an underbuxor Creo expressing under the early stages of early stages of hematopoietic development, under the short-term, long-term stem cells of multipotent progenitors. Although they take about 9 to 10 months to start getting sick. When we actually, I didn't show the data here, but when we expressed them under C11C Cree mice, it was even longer before they started developing disease. So we're seeing a much more aggressive diseases initiated at early stage of myeloid development in the mouse models, although it's much less aggressive than BRAF V600E or MAPK mutations when they're expressed at earlier stages of hematopoietic development. And we also see the suppression of B lymphopoiesis and a major expansion of the monomonocytic subsets, including particularly the monocyte and macrophage subsets, like we do typically in histiocytosis patients, like we've seen in other mouse models of histiocytosis, such as BRAF when it's under C11C Cree BRAF, as well as the MEK1 mutant mice. And so additional NOACA mice, again, may be useful for looking at other therapies or combination therapies. Although we know MEK inhibition works for these patients clinically, how do more specific inhibitors work in these mice, such as dimerization inhibitors for RAF, dimerization inhibitors, RAF degraders, things like dimerization degraders, how do those things work? These are the mouse model, although now it seems to be a type of, initially at least, has some histiocytosis, given some idea of some kind of systemic disease, similar to histiocytosis, we can potentially use it to study further ARAF analysis and how it affects neoplastic hematopoiesis, also how any therapy can be utilized actually as combination therapies or preclinical trials to see what else could be useful in ARAF-driven histiocytic disorders. And of course, this is earliest stages of the characterization of mice. Many other future directions that we'll be taking, of course, looking at the single-cell RNA sequencing of the different subsets, the macrophage subsets, how it affects the lymphocytes on the bone marrow, the spleen, different subsets. We've also got to demonstrate that these can transplant, transplantable disease like we did in other mouse models, can actually into lethally irradiated and recipient mice. And of course, we have to studying the microenvironment as well, and understand it. Also do even more extensive flow cytometry analysis using spectral flow to study the microenvironment even more extensively. So, thank you for your attention, and I'll take any questions at this time about this new mouse model, the first one of ARAF in the world. So.